Good morning, everyone. I have 12:01, but I think we're going to take an extra minute just to let additional people sign on to make sure that they're in the right meeting. We do have a poll this morning that I've set up, so if you could take a second and please fill out your role, we would very much appreciate those responses. Thank you so much. All right, with that, I'm going to go ahead and end our poll, and we can go ahead and get started. So good morning and welcome to the Fairfax County Health Department's Communicable Disease and COVID-19 updates for long-term care facility partners. This is our March webinar, and we are excited to have you on board. My name is Samantha Christensen, and I'm the Fairfax County Health Department's HAI Epidemiologist. I'll be providing some of our webinar updates in coordination with Carlene Thorton, who is coming on to provide some updates about the medically fragile task force. And without further ado, I will pass things over to Carlene. Carlene, would you like to please unmute yourself and go through your slide deck for us?
Good morning, everyone. So this is going to be a brief overview of the Medically Fragile Task Force, what we do, and the most effective and efficient way to receive services from us, and also to give you some guidance on becoming self-sufficient. So well, to start, I would like to say that most of you have my contact information, and I will definitely provide it in the chat and at the end of the presentation, as well as introduce you to Matthew Fondin, who will be assuming the leadership role over the Medically Fragile Task Force. So you will have Matthew's contact information as well. And I also sent out an email earlier this week to our long-term care facilities, and we will send another email out on Monday to make sure you have all the information we covered today, as well as Matthew's contact information. So to get started, we are still here to assist you with receiving the COVID-19 vaccinations for your residents. And this is for the residents and not the staff members. The staff are encouraged to utilize the various options at their disposal. So when you make a request for us to come out and provide the vaccinations to your residents, please use the forms that we provide you. And the registration form is on top and the consent form is on the bottom. Complete the registration form with their name, which vaccine it is, the dose. The reason that is important is because whether it's Pfizer or Moderna, the time period between doses and the dosage is different. So it's important that we have the accurate information. We will check and verify. However, if you provide us with the most accurate information on the front end, it eliminates confusion and us double checking with you, because if what you have matches with what we have, then we can proceed with scheduling and coming out to vaccinate. However, if there is a discrepancy, then we'll have to do a little back and forth to ensure we have the accurate information. It is also important that you double check the date of birth. because we definitely need the date of birth to properly record the information, and also to search for them in this, because there are a ton of David Smiths. So we need to make sure we have the right date of birth for the right client. Additionally, please take the time to put the first name in the first name column and the last name in the last name column, and be consistent throughout the document. We have received forms where we have a first name, last name, and then a switch. And if it's recorded wrong when we receive it, it's also recorded incorrectly in VAMS and VIS. So that makes it difficult for us to locate the person at future times. So please take the time to make sure you are putting the right information in the appropriate place. And for some names, it's difficult for us to tell which is the first and which is the second if they're switched. Some names is pretty simple. Mary Johnson, Johnson is the last name, even if it's reversed. But some names is difficult to tell. So please make sure you put the proper name in the proper place. Also, the consent forms. The consent forms you hold on to, and it will need to be completed. It will need to be completed for each resident, and it should be completed beforehand and ready for our vaccinators when they arrive. Once the vaccinators get there, unfortunately, we do not have the ability to wait an hour for consent forms to be located, filled out, family members tracked down, the proper nursing staff tracked down to have these forms signed. So it is important to complete the consent forms beforehand and have it ready when we come out. And if you're not going to be there, please notify whomever is in charge or will be responsible for assisting us. Please let them know that we are coming. So they'll be prepared for us and they'll know who we're coming to vaccinate. Additionally, if anyone is discharged or in the hospital, if for whatever reason they won't be there during the time we are scheduled to come out, please notify us as soon as possible so that we can schedule other individuals in their place, or prepare to reschedule your facility if there's only one person that you requested. And we will come out for one person, 5 people, 10 people. You don't have to wait until you get a whole list of people for us to come out. We will come out for one person. Now, with that being said, we are still here to help you, and we will continue to assist you with vaccinations. However, the goal is for you to become self-sufficient. And there's several steps you need to take to become self-sufficient. And it starts with completing the CDC's vaccination form. Can you advance the slide, please? So the link and all of this information will be put in the chat for you. Once you go to the link on top to complete the process to vaccinate in-house, the screen should look like the picture that is shown right there. And I'll also send you the instructions, which will take you through step by step of the process that you should follow in order to be able to vaccinate in-house. If you choose not to vaccinate in-house, you can partner with an outside pharmacy so that they will come in and provide the COVID-19 vaccination for your residents. However you choose to do it is totally up to you. However, we need you to start the process as soon as possible if you have not already started. And we will continue to assist you until that process is complete. And once you've started the process and completed all of your paperwork, please let your liaison know, and we will do our best to have your application expedited so that you will be able to vaccinate on your own as soon as possible. So start the process as soon as possible, and until that process is complete, we will still be here to assist you. Next slide, please. Some of the requirements to vaccinate in-house is you will need a lockable refrigerator and a digital data logger. And what the digital data logger is, it continuously monitors the temperature, and it provides a digital download to where you can download and save that data electronically to let you know and to ensure that the vaccine remains at the proper temperature throughout the entire time. And once you start the process, you'll get a packet that has signs to say, do not unplug this refrigerator, and very other important signs that you need to know. And you'll also be given information once you get approved for the documents you have to sign, proper storage and transportation. There, you will be provided with a lot of information, and I will definitely share many of these links with you at the end of the presentation. So we are definitely here to help you. However, we need you to start this process as soon as possible. Next slide, please. Here is Matthew Fondon's email address. If you are not the COVID-19 vaccination contact person for your facility, please send that information. Or if you are, please send us your information if you have not received an email from me, Carlene Thorton at fairfaxcounty.gov. If you have not received that information, an email from me, please send Matthew your information along with the name and address of your facility so that we can include you on our email list that we send out from the Medically Fragile Task Force to provide you with important information if there's a change in the time period between doses, or if there's a change with the vaccine. Anything or scheduling processes, we will send that information out to you. If you are new in your role, or if you have not received the information from me, an email from me, please send your information or the appropriate COVID-19 schedulers information to Matthew, and we will be sure to include you on our email list when we send out email blasts to let you know important information about the COVID-19 vaccine and vaccination scheduling. Thank you very much. And that's all I have. I will not be on for the duration of this meeting. However, if you pass along your questions, we will be sure to get them answered, and you will have a reply by Monday morning. If not by the end of the day, you will get a reply soon with any questions that you have for me.
Thank you so much, Carlene. It's an absolute delight to have had you on the call today. We are going to very quickly reopen the poll that we had as our entry poll to allow some of the additional members who have joined this call to fill out their information there. So if you could please at this point fill in the information here. If you've already submitted a response, if you would not mind submitting it again, we would greatly appreciate that information just so that we can keep tabs on kind of who we're able to reach out to as we're moving forward. I'm going to give just a couple more seconds for any stragglers so they can go ahead and fill out the poll, and then we can move on with the rest of the presentation. All right, thank you so much for your responses. Moving forward, we're going to, as a brief outline for today's meeting, first we'll be talking about a COVID-19 situational update for our long-term care facility providers. Then we'll move into our CDC community transmission levels before providing influenza updates, a brief CDC guidance review from February 2nd, a CRO hot topic discussion, some VDH lab reporting training, and then some Q&A to follow up our presentation. So for the first time in several months, our COVID-19 case rates have decreased across the country. I've listed the country maps from February and March, as well as the breakdown of counties side by side here in order to show the rapid decline in cases over this time period across the country. 2,045 out of 3,220 counties are experiencing a high level of transmission. When we last met, 99.8% of counties in the United States were at this level of transmission. Now only 63.47 are in the high level of transmission. You'll note that Fairfax County is one of the counties included in this decrease as we moved from a high level of transmission to a substantial level of transmission in March. There are currently 802 counties in the United States at a substantial level of transmission, which is up from 0 when we last met in February. Similarly, the counties in a moderate level of transmission have increased, moving from only a single county in February to 314 now in March. Finally, there are 59 counties in the United States at a low level of transmission. This is an increase from 4 in February and is a result of more counties across the country experiencing a reduction in COVID transmission. At a state level, case rates in Virginia have decreased or plateaued across all districts. Virginia has experienced 115.2 cases per 100,000 people within the past 7 days, which is a reduction of 83% of the rate when we last met in February. This rate is lower than our neighbors in North Carolina, West Virginia, Tennessee, and Kentucky, with rates at 172.8, 269.8, 149.4, and 191.7 per 100,000, respectively. DC and Maryland host case rates that are lower than Virginia, with DC experiencing 79.9 cases per 100,000 in the past 7 days, and Maryland experiencing 59.9 cases per 100,000 in the past 7 days. Overall, the US average rests at a rate that is slightly lower than what we're seeing here in Virginia, with 111.8 cases per 100,000 over the past week. Within Fairfax County, case rates have spiked throughout December and January. At its highest, Fairfax County experienced 3,185 cases in a day. At its most recent point, there have been 193 cases reported in a day, with a 7-day rolling average of around 134.7 cases. This illustrates a very rapid acceleration of cases with a steady and similarly paced decline of cases. We've also included a gauge that depicts the level of transmission in Fairfax County. Currently, and as mentioned before, Fairfax is at a substantial level of transmission, dropping from high where we have been for the past several months. Fairfax County long-term care facilities have experienced a wave similar to their wave at the start of the pandemic, with sustained case volumes over the past several months. This contrasts with the curve for the general population in Fairfax County, where this wave experienced rapid acceleration and then deceleration of novel cases. Only recently has the influx of new cases in long-term care facilities begun to maintain lower case volumes, with the highest peak in long-term care on December 30th with 99 cases in a day, and the most recent peak on February 28th with only 8 cases in a day across all facilities. Notably and very encouragingly, while we witnessed high case counts during the most recent wave, these cases typically have better outcomes than cases in the previous waves. These charts illustrate the quantity of hospitalizations and deaths throughout the pandemic. You can see that the highest level of hospitalizations and deaths in long-term care facilities occurred during the first wave of the pandemic, with a second spike in these counts during the winter of 2020, and a noticeably reduced spike during the most recent Omicron wave in the winter of 2021. This decrease in the quantity of hospitalizations and deaths is a testament to the efficacy of vaccination in preventing severe outcomes in long-term care populations. Now, as a brief update, currently there are 10 COVID outbreaks in Fairfax County skilled nursing facilities, 4 in Fairfax County assisted living facilities, and 2 in Fairfax County group homes. This is a large decrease from our levels in February, where 14 SNFs, 25 ALFs, and 8 Fairfax County group homes were experiencing COVID-19 outbreaks. Next, we'll move into a discussion on the CDC's new community transmission levels. So for the general population, the CDC is moving away from the community transmission levels you're familiar with in order to implement new metrics that focus on the health outcomes of the community. This is in response to a shift from eliminating SARS-CoV-2 transmission towards more relevant metrics given the current levels of population immunity, which are known to reduce the risk of severe outcomes. The indicators for community transmission that will still be utilized for long-term care facilities take into account the total new cases per 100,000 persons and the percent positivity over the past 7 days. These levels will continue to guide changes in infection prevention and control measures in your facility. For the general population, new measures were developed to guide decisions about personal risk given the level of severe outcomes in the community. 2 new indicators were selected to best account for severe outcomes in this community. So for the first incorporates the new hospital admissions with confirmed COVID-19 infection per 100,000 people. And the second utilizes the percent of inpatient beds that are occupied with COVID-19 patients. This ensures that new severe cases and persisting severe cases are incorporated into the level of community transmission. These indicators were selected in order to provide better predictors of deaths and ICU utilization in the general population. So for this general population, the community levels are broken into low, medium, and high, and residents should adjust their COVID-19 prevention activities based on this level in the community. When at a low level, CDC recommends staying up to date with COVID-19 vaccines, getting tested if you develop symptoms. And at the medium level of transmission, CDC recommends that people who are at a high risk for severe illness consult their healthcare providers to determine whether a mask or other precautions might be right for them. At this level, the CDC recommends continuing to stay up to date with COVID-19 vaccines and getting tested if you do develop symptoms. Finally, at a high community level, the CDC recommends wearing a mask indoors in public, staying up to date with COVID-19 vaccines, continuing to get tested if you have symptoms, and exploring additional precautions for people that are at a high risk for severe illness. At all levels of transmission, improved ventilation should be maintained throughout indoor spaces, and CDC recommends for isolation and quarantine recommendations should be followed. And those who are immunocompromised or present a high risk of severe disease should have a plan for rapid testing and talk to their healthcare provider about treatments like oral antivirals, PrEP, and monoclonal antibodies. So to kind of show the difference between the new community level and our typical community transmission that we will continue to use, this slide shows basically 2 of our types of transmission as a snapshot. And the snapshot comes from July 30th, 2021. And you can see there's a noticeable difference in the conveyed level of transmission and severity in the community. So using the community transmission level on the right, we can see that 61.3% of counties were in a high level of transmission based on total new cases per 100,000 and the percent positivity in the overall population. Many counties across the U.S. fall into these higher levels of transmission, with only about 20% of counties in a low to moderate level. With the focus shifted to severe outcomes due to COVID-19 and using data based on hospital admissions and filled beds due to COVID, this high level drops to 30.1%, or just under 1/3 of counties in the United States on the left. When accounting for severe outcomes instead of case volume, the low and medium levels account for just under 70% of U.S. counties. Comparing the two charts assists with identifying locations where the population is experiencing the highest quantity of severe outcomes due to COVID and can help more easily guide prevention strategies to high target areas. Now, this map shows the current COVID-19 community levels across the country. Currently, these rates have a high level of heterogeneity, with the majority of counties at a low or moderate level of transmission. With this new community level, it's easier to spot that there are areas that are experiencing severe outcomes due to COVID-19, such as a cluster of high counties near West Virginia, Kentucky, and Southwest Virginia. Prevention strategies for this bubble will include the recommendation to wear a mask in indoor public spaces, regardless of vaccination status, and considering self-testing or wearing a mask when you have contact with someone at a high risk for severe disease. Now, probably the most important slide for this kind of switch in overall guidance from CDC is to kind of emphasize that these community levels will not affect long-term care facilities. So while they are general recommendations for the population at large, they do not apply to healthcare settings such as hospitals and nursing homes. So our long-term care facility community will continue to utilize the community transmission levels based on new cases per 100,000. The CDC has moved these transmission levels on their homepage, so now the community levels for severe outcomes are more prominently displayed. Please don't use these levels when making considerations for your facility. Instead, the link provided here on the slide will take you directly to the data for the transmission levels that we have continued to use throughout the pandemic. And additionally, very briefly, I'm going to show a brief demonstration on how to navigate to these metrics so that you can find them from cdc.gov. So here you can see I've pulled up the CDC website. This is just www.cdc.gov. And from here, if I looked at the main page, you would see there's a county check, and this will show you the new model that's based off of severe outcomes and not what we'll be using for long-term care facilities. So instead, what I'll do is I'll select diseases and conditions and click on coronavirus. From there, there are several tabs here at the top, and I'll move over to cases and data. To find the rates that we'll be looking at for Fairfax County, I'm going to click on your community and then the county view. And from here, you can see the model of the United States that we're most familiar with our high, substantial, moderate, and low transmission levels. From here, I can select the state that we're in as Virginia, and I can select our county as Fairfax County. This will allow you to see the level of transmission for our county that you should use to base your policies for your facility on. Looking here, you can see that our transmission level is substantial. Next, we'll provide a brief update on influenza in our community. Our preliminary data for MMWR Week 7, which ends on January 29th, reports the proportion of influenza-like illness visits to the emergency departments and urgent care centers is at 1.2% in the Fairfax Health District. The influenza activity level in Virginia has been reported at the sporadic level, which is very low for the MMWR Week 6, with the northern region at a minimal intensity level of influenza-like illness. This chart on the left depicts the current influenza season and the previous 5 seasons to serve as a comparison. This year, we witnessed trends in emergency department and urgent care center visits similar to that of the flu season from 2019 to 2020, depicted here in orange, until very recently, where levels of influenza-like ED visits have declined to a similar level to what we witnessed in 2020 to 2021. On the right, the intensity level of influenza-like illness has been categorized by region. And you can see in the Northern District, as well as in the rest of the state, we were witnessing a minimal level of intensity. Since the 2021 to 2022 season has started, Fairfax County has only investigated one influenza outbreak, and the percentage of ED visits for influenza-like illness for the county is well below the national baseline. Moving into our next topic, we wanted to provide a brief review of some of the major changes from the February 2nd guidance. The two guidance documents that were updated on February 2nd were the interim infection prevention and control recommendations to prevent COVID spread in nursing homes, and the interim infection prevention and control recommendations for healthcare personnel during the COVID-19 pandemic. You can find links to these documents here, and they'll also be provided in the slide deck after the presentation. Several points of these guidance, of these updated guidance documents have been based on the term up to date in regard to vaccination. A person in your facility, whether it is a resident or a staff member, is considered up to date after the receipt of their booster for all vaccine types. So for the Pfizer vaccine, booster doses are recommended for all people aged 12 and up, 5 months after their last dose in the primary series. For the Moderna vaccine, booster doses are recommended for all people aged 18 and up, 5 months after their last dose in their primary series. And finally, for the J&J vaccine, booster doses are recommended for all people aged 18 and up, 2 months after the receipt of their vaccine. We have received some questions about the CDC guidance on quarantining new admissions and readmissions. So we modified this table from last month to help clarify when to quarantine these residents. So residents who need to quarantine include those who are symptomatic, regardless of their vaccination status, those who are exposed and not up to date on vaccination, and new admissions or readmissions to your facility who are not up to date on vaccination. Residents who do not need to quarantine include those who are exposed and have either received a booster dose of vaccine and are up to date, or have recovered from COVID-19 within the past 90 days. New admissions and readmissions who are up to date do not need to quarantine upon entry to your facility. And finally, of course, if a resident is unexposed or asymptomatic, they will not be required to quarantine. When it is time to end quarantine, residents may be removed after 10 days if they do not develop symptoms, or 7 days if they do not develop symptoms and have a negative viral test. In order to be removed from quarantine, residents should be tested within 48 hours of the planned re-entrance to the cold or green unit in your facility. When counting the total number of days to quarantine, please keep in mind that the date of the exposure event will serve as day 0. So if a resident were to need to quarantine for 10 days, they must be in quarantine for 10 full days after their exposure date. This means if a resident was exposed on March 1st, their last day of quarantine would be March 11th, and they could join the cold unit on March 12th. Moving into testing for long-term care facility residents, the updated CDC guidance recommends that anyone with even mild symptoms of COVID-19, regardless of their vaccination status, receive a viral test as soon as possible. It also states that newly admitted residents or residents who have left the facility for a period greater than 24 hours, regardless of their vaccination status, should be tested both immediately upon entrance to the facility and, if negative, again 5 to 7 days after their admission. Finally, residents who have been exposed should have a series of 2 viral COVID tests performed, regardless of their vaccination status. And then for staff testing, the guidance document released on February 2nd provided some updated recommendations. While before, fully vaccinated staff were exempt from routine facility-wide testing based on the level of community transmission, under this new guidance, staff must now have received a booster dose to exempt them from routine testing. The frequency of this testing is based on the community transmission level, and that stays the same, with staff not up to date on vaccination required to test twice a week at the high and substantial levels of transmission. At the moderate level of transmission, this routine testing can occur once a week, and at the low level of community transmission, this testing will not be recommended for long-term care facility staff. Fairfax County, again, is at a substantial level of transmission, so staff who are not up to date on vaccine should be tested twice a week. CMS has not yet updated the routine testing requirements to match CDC's new recommendation, Their QSO 2038 recommendations were last updated in September of 2021. The level of community transmission, if you're hoping to look it up in response to this sort of testing, can be identified through the COVID data tracker. There's a link provided to that in the slide deck, and we also went through a brief demonstration on how to make your way there as well. Now for source control, the CDC has recommended that source control and eye protection for all healthcare personnel involved in resident care be donned at both the substantial and high levels of community transmission. During these periods, source control using a NIOSH-approved N95 or higher level respirator should be worn during any aerosol generating procedures, any surgical procedures that may pose a higher risk of infection, interactions with residents who are not up to date on vaccination, interactions with residents who are unable to use source control, and during work in poorly ventilated areas of the facility. The CDC urges facilities in substantial or in high levels of community transmission to consider the universal adoption of NIOSH-approved N95 higher level respirators for all resident interactions, or for specialty units in the facility that may have a higher risk of SARS-CoV-2 transmission. So since Fairfax County is now in the substantial level of transmission, we wanted to review the PPE that should be worn at this level. This table is divided into the community transmission levels and the action taken by your staff. And if you've attended this call before, you're probably relatively familiar with this table. So whether your staff are working with a patient or working with a who is suspected of having a SARS-CoV-2 infection, or with a patient who is not suspected of having a SARS-CoV-2 infection, will impact the type of PPE that they don. At the substantial level and through the high level, you'll see that PPE operations will remain the same, meaning that staff should continue to wear a gown, gloves, eye protection, and an N95 or higher level respirator when working with suspected or confirmed COVID-19 cases. When working in the nursing units of the facility or working with a resident who is not suspected of having a SARS-CoV-2 infection, staff can continue to wear source control and eye protection. For our next topic, and as we kind of continue operations into the summer, we wanted to discuss and review healthcare-associated infections and antimicrobial threats in your facilities. So today we'll talk a little about one serious threat to long-term care facilities, which is highly antimicrobial resistant CROs, or Carbapenem-resistant organisms. So what are Carbapenems? Carbapenems are a class of broad-spectrum antibiotics that are reserved to treat serious multi-drug resistant infections. Carbapenems inhibit cell wall synthesis by binding to penicillin binding proteins, which are called PBPs, the normal target of beta-lactam antibiotics. This binding process prevents peptidoglycan synthesis, which is critical in the construction of the cell wall. Disrupting cell wall construction can eventually lead to lysis, where the cell ruptures due to osmotic shock. Due to the ability of carbapenems to disrupt multi-drug resistant organisms, or MDROs, they are often considered antibiotics of last resort to treat a bacterial infection. Now, carbapenem-resistant organisms have four main mechanisms of carbapenem resistance: porum mutations, efflux pumps, PBP mutations, and carbapenemase development. At number 1 on the slide, mutations in the porins can result in reduced uptake of the carbapenem antibiotic into the cell. Efflux pumps at number 2 channel the carbapenem outside of the cell, reducing its ability to bind with the target PBPs. Similarly, novel mutations in penicillin binding proteins at number 3 can make carbapenems unable to properly adhere and reduce peptidoglycan synthesis in the cell wall. Finally, at number 4, carbapenemases are proteins developed by the pathogen to inactivate carbapenem antibiotics. Carbapenemases observed in Virginia include Class A KPC mechanisms, Class B IMP, NDM, and VIM mechanisms, and Class D OXA48 and other OXA mechanisms. Now, carbapenem resistance is an ongoing public health problem of global dimensions. This form of antimicrobial resistance has witnessed increased spread and can lead to infections and outbreaks with limited treatment options. Infections with these organisms can include bloodstream infections, ventilator-associated pneumonia, and urinary tract infections, and are associated with high mortality rates among hospitalized patients, up to 50% in some studies. The CDC considers carbapenem-resistant organisms and other multi-drug resistant organisms an urgent threat to the United States, which is their highest level of threat to public health. Because carbapenemase genes are often located on plasmids, or genetic material that can be shared across different organisms, resistance to our last line of defense, antibiotics, can be transferred to otherwise susceptible organisms. CDC advises aggressive action in responding to CROs, including collecting and submitting patient samples for testing at public health departments and regional labs. This early identification can allow healthcare facilities to take action to contain bacterial spread. Currently, healthy people do not typically get CRO infections. These infections typically occur in patients of healthcare settings like hospitals and skilled nursing facilities who may have underlying health problems. People who require devices like ventilators, urinary or intravenous catheters, long courses of antibiotics, or who may be immunocompromised are most at risk for a CRO infection. Healthcare-related risk factors include requiring help with most activities of daily living, like toileting and bathing. Patients who are frequently exposed to antibiotics are also at a high risk of acquiring CROs. Carbapenem-resistant organisms are transmitted from person to person, often via the hands of the healthcare personnel or through contaminated medical equipment, stool, or wounds. Sink drains and toilets are also increasingly recognized as an environmental reservoir and CRO transmission source. So identifying patients colonized with CROs is beneficial for controlling the spread of disease and for allowing providers to prescribe optimal antibiotics when deemed medically necessary. Residents may be colonized with a CRO without experiencing the adverse effects of an active infection. However, episodes of infection are often preceded by this colonization. For this reason, preemptive screening can prevent patient-to-patient transmission and provide early and appropriate therapies to be administered. VDH recommends screening for CROs during admission from high-risk settings, such as ICUs or other skilled nursing facilities, and as a measure for contact investigations. During screening, rectal swab specimens are utilized to identify CRO colonizations and infections. CRO carriage is a lifelong status, meaning that once a resident is identified as having a CRO, transmission precautions will always apply to them. When residents are transferred to healthcare settings, staff are required to notify the receiving facility about the infection or colonization so they can place the resident under contact precautions. Knowing the colonization status of your residents through screening and communication with other facilities is a great way to protect the health and well-being of your resident community. Our next and final topic before opening up to Q&A goes over the VDH reporting portal. So to start off, we wanted to dive into the 3 tabs of the VDH reporting portal. The first is the COVID-19 reporting tab, which is tab 2. Then we'll talk about the COVID-19 bulk reporting tab, which is tab 3, and the daily aggregate reporting of negatives, which is tab 4. The second tab in the VDH POC portal is this COVID-19 reporting tab. And this tab allows users to manually report patient information on the tests a resident or staff member received in your facility. Patients can be searched using from the landing page here to look for historical data. By selecting the Add Patient Information button at the top right of the screen, a user can add data for a new COVID case in the facility. Please note that this section is only for reporting positive test results. You'll be taken to a patient information form after you click this button, where you can enter the data of this new case. This is where you can list the basic demographic information about the case, including their name, their date of birth, their gender, race and ethnicity, address, and phone number. If you are reporting a new resident or staff member in your facility, and perhaps it's a staff member who lives outside of Virginia, the state drop-down field has an option that's titled XX that you can select to indicate an out-of-state address. The next sections you'll see include a test information and supplemental information on a case. This is where you can kind of report that direct positive lab information from someone who tested positive in your facility. Here you'll find fields for the test date, the specimen number, the manufacturer or model of the test performed, the qualitative result, and the specimen type. After pressing save in this section, the specimen ID will be automatically generated. So that's not something you'll have to worry about filling in. The supplemental information section can be used to record any additional information about this case. You'll note that there are sections here that ask specifically about healthcare settings and congregate care. If you have a staff member that you're reporting, please select the "Is this patient employed in a healthcare setting" option. If they are a resident of your facility, please use the "Does this patient reside in a congregate setting" field. Should your resident or staff member have experienced symptoms of COVID-19, these symptoms and the symptom onset date can be recorded here as well. By pressing save, this data will be saved, and by selecting save and add new instead, the existing record will be saved and a new screen would appear with the next patient open so that you can fill in their information. Once these labs are submitted into the VDH lab reporting portal, they will appear as pending, and then afterwards they will be processed by VDH and their status will be changed to process as well. If a record here needs to be edited, there is an edit pen icon on the home screen that can be used to edit each record. After the status has been changed to processed, however, this record can no longer be edited. Now, the third tab on the VDH POC portal is one that might be most interesting to many of our facilities. Instead of the kind of manual reporting that can be done using the second tab on this panel, the third tab will allow you to bulk upload your data. So this is used for kind of mass positives that need to be reported at once. Users who would wish to use this third panel of the VDH portal will have to request access through VDH. However, we wanted to kind of showcase what this might look like to help you navigate it if you wish to opt into that function. So to begin a new bulk upload, first what we'll do is we'll select the manual bulk upload option that's highlighted here in yellow. From here, you'll be taken to a manual bulk upload section, and the data that you report through the portal will be read through a CSV file. A template is available using the blue hyperlinked download template link at the top in order to make sure that the data is formatted correctly for the upload. I've added a snippet here of the CSV template. After filling in the test results and other demographic and personal information that's required in the template, you can save this file on your computer and then upload it using the Choose File button on the manual bulk upload screen. By pressing the blue Upload button, the data in the CSV file will be uploaded. A message will appear to confirm your intention to report these positive labs before continuing. And any errors that might have occurred in your formatting of the data will bounce back with an error message, and you'll also be sent an email summary at the end of your bulk upload, just to confirm that these are the people and the lab results that you wanted to report to VDH. The final tab that we'll discuss hosts data on negative tests. So the first tab, which is the COVID-19 reporting tab, allows you to manually report a single positive case, or several if you continue to press the Add New function. The COVID-19 bulk reporting section allows you to add multiple positives all at once by using a CSV file. And then this fourth tab allows you to report negative tests. And the formatting for these will be different in that there'll be a aggregate total of negative tests instead of a specific negative test for each person with that demographic information. So this allows you to kind of quickly report the number of negative tests that came about as a result of your internal testing. By selecting the Add Daily Aggregate Negatives button, the count of negative tests can be added to this portal. You'll be brought to a form with fields for your facility name, the manufacturer or model of the test date, and the total negatives. After these numbers have been added, users can select the Submit button to record their negative results. Now, many of our facilities are required to report through NHSN, and we wanted to clarify here that facilities will only ever need to report to one system. So if you are using NHSN and you are using the VDH portal, you do not need to duplicate these efforts. You only need to report to one of these systems. So typically, this will be NHSN for most of our facilities. And when you are reporting through NHSN, there are sections in that will allow you to report aggregate data, but we very strongly encourage you to use kind of that more personal level data, as this allows us to have lab reports and results populated into our data systems. VDH is issuing a reminder to nursing homes that they're required to report individual point of care results and not summary data to NHSN. But we also wanted to mention it here to make sure that that message was well received. Additionally, as kind of an update and reminder, the CMS vaccination requirement for healthcare facilities is now being enforced in the state of Virginia. CMS provided a brief pause on this enforcement to allow facilities to ensure all staff had been vaccinated due to the high vaccine booster dose demand. But as of Monday, February 28th, in order to be in compliance with CMS, all eligible staff must now be fully vaccinated. Here we've provided a link to CMS's FAQ document for additional questions about the vaccination requirement. And finally, we did want to provide a link again. We sent this last month as well, but we wanted to reemphasize that CDC has a little mini webinar series that's available for the training of long-term care facility staff. These are 5 short webinars that review basic infection prevention steps that are essential for preventing the spread of COVID-19. And they include environmental cleaning, hand hygiene, screening for residents, strategies to keeping COVID outside of your facilities, and PPE. You'll note that each of these training videos is roughly 7 minutes long, so that makes them very digestible and really easy for staff to view and review later. We did want to open a polling question where we wanted to discuss some of the training needs for your staff as well. So I'm going to launch this too, just to kind of get a view on what are the training needs of your staff, what are those priority needs, so that we can hopefully aim to address them and assist with some of those training needs. All right, I'll give everyone a couple more seconds to fill in the poll, and then we can go ahead and close it. All right, thank you so much for your responses. We really appreciate this, and we'll use it to kind of guide some of our future topics of discussion and training modules. So to kind of round things off, we wanted to, of course, provide our contact information. Our main number is 703-246-2433, and our CD emergency phone for after hours and weekend calls is 703-409-8449. We wanted to thank you so much for attending. We do have one more poll to fill out. So we did want to ask our facilities how they are currently tracking vaccinations, and I'll launch that now very quickly. This is something that we're interested in, identifying with our facilities to kind of see if there are ways that we can assist maybe with some of that internal tracking. Okay, I'm going to give it a couple more seconds for this poll before we close it out. All right, thank you all so much for your responses. This is our first time using these polls, and we're very excited. I think that they're a very interactive way to kind of go back and forth with our facilities, so we're beyond excited. We'll now open up to a Q&A session. We want to first of all thank you all so much for attending, and we hope that you can join us next time on Friday, April 1st from noon to 1 p.m. I'll now turn it over to the chat, and I can see we do already have some activity there. Let's see. I do see a first question here that says, a long-term care facility recently had a question about whether or not staff who are not yet eligible for a booster dose less than 5 months after their second Pfizer or Moderna vaccine need to be included in routine testing, that twice a week during substantial community transmission testing. Please advise. So if you have someone who is not yet eligible for a booster dose, they do not need to be included in your routine testing for staff until they meet that eligibility requirement. At that point, if they have not received their booster dose, then they would enter the flow of staff members who are being tested twice a week. I see one other question from a long-term care facility. Are facilities required to report cases in NHSN, or is this recommended? So facilities are required to report cases in either NHSN or in the VDH reporting portal. I believe NHSN is typically only used by skilled nursing facilities unless you have gone through the extra steps as an ALF to be provided NHSN access. However, this means that one of the two, if your facility is using that kind of in-house testing, should be completed. And that this should also be something that's completed not as an aggregate count, but as an individual case-by-case level basis for positive results in your facility. And I see Barbara's also helped with responding to the vaccination question. So thank you, Barbara. I'll leave the floor open for a couple more minutes, but we are at 1 o'clock. So if you need to, please feel free to hop off the call, and we look forward to seeing you again next time.